Hello everybody. Today we are going to discuss acute liver failure case as well as guidelines which was published by ACG. So we have this 36-year-old male patient who was a known case of chronic liver disease, disseminated TB, and on AKT since 9 months and also umbilical hernia. He came to us with the chief complaint of abdominal pain, swelling over left lower limb, difficulty breathing since 2 days. So patient was referred from the outside hospital where he was admitted with the abdominal distension, swelling over both lower legs and the breathing difficulty since 2 days. He was admitted there from the 9th of February to the 13th of February, and he was diagnosed with the decompensated CLD, spontaneous spectral peritonitis, and the acute kidney injury. On arrival in ICU, his vitals were stable, but his GCS score was low, which was E2, V1, M3. Bilateral pedal edema was present and the JVP was raised. So patient was intubated in view of low GCS. And USG after pelvis was done for this patient, which showed liver normal in size, poor texture, and the nodular margin. Gross ascites was present, splenic vein was dilated, and gallbladder was partially distended. So as we all the blood investigation was sent, and we found the LFTs of this patient was normal, except the INR which was mildly elevated. And then we have this another patient who is a 48 to 40 years old male patient diagnosed with the steatohepatitis with cirrhosis. He presented to us with the chief complaint of yellowish discoloration of the skin and eyes since 2 to 3 months, difficulty breathing, abdominal distension, decreased urine output since 2 to 3 days. His outside reports were like this. Bilirubin was 29. As we can see, SGOT, SGPT was highly deranged. And these are his investigation on the next day. So his bilirubin was 34 here, SGOT 220, alkaline phosphatase and GGT was also raised. So we have seen the two patient of acute decompensated liver disease. In first patient, our LFTs were normal, and in second patient, the LFTs were highly deranged. Still we label the both the patient was acute and chronic liver failure. So I was wondering what is the exact definition of the acute and chronic liver failure, and I went to this ACG guidelines. So I found there are three definitions to who defines the acute versus chronic liver disease. So we'll see the first definition, which is the Asian Pacific Association of the Study of the Liver, which defines ACLF as acute hepatic insult manifesting as a jaundice with the serum bilirubin level of the 5 and coagulopathy with the INR of 1.5, which was complicated within the 4 weeks by clinical ascites and hepatic encephalopathy in patient with the previously diagnosed or undiagnosed CLD or cirrhosis and is associated with the 28-day mortality. So according to this definition, extrahepatic organ failure was not required to satisfy this condition. The next definition was the European Association for the study of study of the liver, that is chronic liver failure consortium, which defines ACLF as a specific syndrome in patient with the cirrhosis that is characterized by the acute decompensation, organ failure, and high short-term mortality. The development of the ascites, hepatic encephalopathy, gastrointestinal hemorrhage, or bacterial infection defines the acute decompensation. However, patient may develop ACLF without the history of acute decompensation. And the organ failures involve liver, kidney, brain, respiratory system, circulation, coagulation, which is assessed by the CLIF Consortium or Organ Failure Score. The North American Consortium for Study of End-Stage Liver Disease defines ACLF by the presence of at least 2 severe extrahepatic organ failure, which is defined as shock, grade 3, grade 4 hepatic encephalopathy, renal replacement therapy, or mechanical ventilation. So ACLF is the potentially reversible condition in patient with the chronic liver disease with or without cirrhosis that is associated with the potential for multiple organ failure and mortality within 3 months in the absence for the treatment of underlying liver disease, liver support, or liver transplantation. ACLF is recognized by the presence of chronic liver disease along with the elevation in serum bilirubin and prolongation of INR. The presence of kidney, lung, circulatory, brain failure supports the diagnosis. And the severity of organ failure may be assessed by the Cliff Sequential Organ Failure Assessment Score or NSC-SCLD Organ Failure Score. Patients with the ACLF are best managed in the ICU, and some may benefit from the early liver transplantation. So these are the variations in the definition of organ failure. So the first definition is the Asian Specific Association of the Study of Liver. So according to this definition, the requirement of the total bilirubin is more than or equal to 5 and the INR is more than or equal to 1.5. And extrahepatic manifestation, they have included this AKI according to the AKI network criteria, and hepatic encephalopathy according to the hepatic encephalopathy grade of 3 to 4. Then this next definition is the European Association for the Study of Liver, which defines the bilirubin should be more than 12, create level of more than or equal to 2, or requirement of RRT, and INR should be more than or equal to 2.5. Plus, patient should have vasopressor requirement, and if the lungs are involved, then the PaO2 FiO2 ratio should be less than or equal to 200. Then the next definition, that is North American Consortium for Study of End-Stage Liver Disease, which defines the involvement of the extra hepatic organ. Like if the kidney is involved, then there should be the need for dialysis or other form of the RRT. That is almost the AKI stage 3. Then if the brain is involved, then the hepatic encephalopathy grade should be 3 to 4. And the circulatory failure with the presence of shock defined as mean arterial pressure less than 60 and reduction of the 40 mmHg in the systolic blood pressure from the baseline despite adequate fluid resuscitation and cardiac output, and the respiration need for the mechanical ventilation. So these are the three definitions for the acute versus acute on chronic liver disease. And if we are encountering with the patient who has developed acute and chronic liver disease, then first thing that we need to find out is what are the precipitating factors responsible for this condition, which includes alcohol, viral hepatitis, drug-induced liver injury, surgery, ischemia, and infection. Then we need to see and then we need to see there are any extrahepatic manifestation is there or not. Then we need to resuscitate this patient properly. While resuscitating, treat the underlying precipitating factor. Treat if infection is there, then the treat infection, and assess for ICU requirement. So if the patient is and also assess for the whether the patient is candidate for the liver transplant. Candidate is eligible for the liver transplantation or not, or also see if there are any extrahepatic organ failure. So if the candidate is eligible for the liver transplantation, then and if there are no extrahepatic organ failure is involved, then evaluate for the liver transplantation. If there are extrahepatic organ involvement, then we need to counsel patient for palliative and end of life care. Then the diagnostic and prognostic biomarkers. Prognostic marker that predict the ACLF outcome should be separated from the diagnostic marker that confirm the presence of ACLF. Microbial composition and microbial origin metabolite can be used as the biomarker for ACLF development and prognosis with further validation. Individual organ failure, that is brain, in hospitalized patient with ACLF, we suggest the use of short-acting dexmedetomidine for sedation as compared to the other available agent to shorten the time to extubation. In patient with cirrhosis and ACLF, we continue to require mechanical ventilation because of brain condition or respiratory failure. Despite optimal management, we suggest against listing for liver transplant to improve mortality. In patient with grade 3 or 4 hepatic encephalopathy, care of airway, evaluation of other cause of altered mental status, treatment of potential precipitating cause, and empiric hepatic encephalopathy therapy should occur simultaneously. Consideration for causes other than the hepatic encephalopathy as the reason for altered mental status is important, especially in patients who have not recovered after hepatic encephalopathy therapies are deployed. Careful monitoring of the pain, delirium, and the avoiding medication that prolongs sedation are important in prompting a return to consciousness. Discussion of the goal of care should ideally occur with patient before the onset of alteration in mental status and should continue after. Patient need to be monitored after they return to consciousness for critically care related post-traumatic stress. Ventilation in the absence of altered mental status should not be considered brain failure. So this is the schematic representation of the patient, of the management of hepatic encephalopathy patient. So initial general care, we need to stabilize airway, blood pressure, triage patient appropriately, send appropriate lab work, start IV fluid, nasogastric feed, then empirical antibiotic if needed. Then we should evaluate for the alternative causes like screen the drug intake properly. Then identify any underlying psychiatric disorder is there or not. Then neurological disorder, delirium, and infection. Then start the empirical therapy for hepatic encephalopathy, that is lactulose, and other therapy for hepatic encephalopathy, and also identify the precipitating factors and reverse it, like infection, GI bleeding, electrolyte disturbance, diuretic overdose, and unidentified. So the next organ that we need to take care of is kidney. And in patient with the cirrhosis and stage 2 and 3 acute kidney injury, we suggest intravenous albumin and vasoconstrictor as compared to albumin alone to improve creatinine. In patient with the cirrhosis, we suggest the use of biomarker. We suggest against the use of biomarker to predict the development of the renal failure. In patients with the cirrhosis and elevated baseline serum creatinine who are admitted to the hospital, we suggest monitoring renal function closely because elevated baseline creatinine is associated with a worse renal outcome and 30-day survival. In hospitalized patients with the cirrhosis and HRS-AKI without high-grade ACLF or disease, we suggest terlipressin or norepinephrine to improve renal function. In patients with cirrhosis and spontaneous bacterial peritonitis, we recommended albumin in addition to antibiotic to prevent AKI and subsequent organ failure. In patients with cirrhosis and infection other than SPP, we recommended against the albumin to improve renal function or mortality. Kidney failure is the most common organ failure in patients with ACLF, no matter how it is defined. So AKI and the chronic kidney disease as outlined by International Club of Ascites should replace the old nomenclature of type 1 and type 2 HRS. So the concept of renal failure in the cirrhosis continue to evolve as we identify the different level of kidney function that can confer the negative prognosis. Other form of the kidney dysfunction that are being recognized include acute kidney disease and acute and chronic kidney failure. Currently, there is no recommendation for the use of vasoconstrictor for stage 1 AKI. The pathophysiology of the renal failure in the cirrhosis is related to the multiple factors, including combination of hemodynamic abnormalities and inflammation. Prevention strategies for the renal failure are recommended for at-risk patients. The treatment option for HRS-AKI include pharmacotherapy, liver transplantation, with or without intervening RRT in the appropriate patient. Patients with the decompensated cirrhosis and ascites should be monitored regularly for changes in the renal function, especially those with the background CKD related to the higher prevalence of the conditions such as systemic hypertension or diabetes. Because AKI in patients with the CKD is associated with significantly worse outcome than in patients with normal baseline renal function. Be vigilant for the potential precipitating factor for AKI development, with bacterial infection being the most common precipitant for AKI in patients with cirrhosis and ascites. Prompt and judicious treatment of potential bacterial infection may avoid the development of the renal failure. Liver transplant is the definitive treatment for HRS-AKI and cirrhosis, and RRT is often required while patients are waiting for liver transplantation. Guidelines for combined liver and kidney transplant are available, but the effectiveness of current policies regarding simultaneous liver and kidney transplant need to be evaluated. The use of RRT in patients with AKI should be individualized. In general, RRT is recommended for patients with HRS AKI who are on liver transplant waiting list and who have failed pharmacotherapy. Refer for liver transplant assessment early in this situation. So this is the schematic representation of how we should approach if the patient has acute kidney injury in the background of acute decompensated liver disease. So if it is a structural renal disease, then we have to treat according to the etiology. If it is functional renal disease, then identify the precipitating cause and treat it. For volume expansion, give albumin according to 1 mg per kg, maximum 10 gram per day. Then we need to, after volume expansion, we need to assess the response. If there is a regression of the AKI, then the close monitoring is needed. If the patient condition is stable, then the further treatment according to the physician decision. Then if there is a progression of the disease, then treat with the vasopressin and albumin if the patient is meeting the criteria of AKI-HRS. If there is no response, then the treat according to the AKI etiology. So even after giving vasopressor and albumin, if the patient is not showing appropriate response, then start renal replacement therapy and also counsel for liver transplantation. Then the next organ that we need to be taken care of is the lung. In ventilated patient with the cirrhosis, we suggest against the prophylactic antibiotic to reduce the mortality and duration of mechanical ventilation. So respiratory failure is defined as PO2 FiO2 less than 200, SpO2 FiO2 less than 214 or need for the mechanical ventilation. Endotracheal intubation is mandatory in patient with a grade 3 to 4 hepatic encephalopathy to facilitate airway management, prevent aspiration and control ventilation. The risk of ventilation associated pneumonia can be decreased by 30 to 45-degree head end elevation and subglottic suctioning. Routine use of sedative is discouraged in patients with grade 3 to 4 encephalopathy and may be associated with the delay in extubate. So we suggest PPI be used in patient with cirrhosis on the ventilator. So the next is the circulation. So higher mean arterial pressure may decrease the risk of ACLF, and the norepinephrine is the vasopressor of choice in the ACLF. So circulatory failure is one of the organ failure that defines the ACLF in both European and the American definition. The EASL cliff defines the circulatory failure as a use of dopamine, dopamine, norepinephrine, epinephrine, or terlipressin. And NSC-SELD defines circulatory failure as a map of 60 mmHg or fall of 40 mmHg in systolic blood pressure from baseline after adequate fluid resuscitation. So when patient with ACLF develop circulatory failure and require pressure support, norepinephrine should be given because of efficacy and favorable safety profile. As a result, their pressure may help to preserve renal function while treating sepsis-induced hypotension. In meta-analysis, the terlipressin when added to norepinephrine did not increase survival over norepinephrine alone. As a cirrhosis, as a cirrhosis and portal hypertension worsen, MAP tend to decrease. And consistent data have shown that higher MAP is protective from ACLF. Some patients with cirrhosis may develop cirrhotic cardiomyopathy, and those criteria have been recently updated. The diagnosis of advanced diastolic dysfunction requires at least 3 of the following 4 criteria. Like if there is a septal early diastolic mitral annular velocity of 7, mitral inflow, early diastolic velocity upon E1 ratio of 15, then the left atrial volume index of 34, then tricuspid regurgitation velocity of 2.8, and in the absence of pulmonary hypertension. Thanks a lot. And we'll continue with the next. So we are continuing with the part two of this acute liver failure case, and so we'll see how to take care of the coagulation if the patient is presented to us with the ACLF according to the ACG guidelines. This in patient with the cirrhosis and the ACLF, we suggest against the INR as a mean to major coagulation risk. In patients with the cirrhosis as compared to the non-cirrhotic population, we suggest there is increased risk of venous thromboembolism. In patients with ACLF and altered coagulation parameter, we suggest against the transfusion in the absence of bleeding or planned procedure. In patients with cirrhosis who require invasive procedure, we recommended use of thromboelastography or rotational tape compared with INR to more accurately assess the transfusion needs. Hypocoagulation found on the TEG and rotational TEG in ACLF is an independent marker of poor prognosis and is usually found in patients with the surge response. In the absence of contraindications such as recent bleeding and the significant thrombocytopenia, hospitalized cirrhotic patients should receive pharmacological VTE prophylaxis. In patients with well-controlled decompensated cirrhosis, low molecular weight heparin may decrease the risk of new decompensation, but inadequate data exist at this time to anticoagulate patients in the absence of thrombosis. Now, regarding precipitating factors like infection, in hospitalized decompensated cirrhotic patient, we recommended assessment for the infection because infection is associated with development of ACLF and increased mortality. In patients with the cirrhosis and suspected infection, we suggest early treatment with antibiotic to improve survival. Antibiotic should be de-escalated once culture and sensitivity are available. First-line antibiotic therapy should be determined by etiology and severity of infection and how it was acquired. Like if it is community acquired healthcare associated nosocomial, and we should also take into consideration about the local resistant pattern. Multi-drug resistant bacterial infection are on the rise and must be considered whenever we are prescribing antibiotic. Alteration in the gut microbial composition and the function associated with the infection susceptibility and acute and chronic liver failure. In a hospitalized patient with decompensated cirrhosis, the presence of nosocomial infection is associated with increased risk of ACLF development and mortality. In hospitalized patients with the ACLF because of bacterial infection who have not responded to antibiotic therapy, we suggest suspicion of MDR organism or fungal infection to improve detection. Because of underlying immune changes, altered gut microbiology, and multiple intervention and admission, patients with cirrhosis they are at increased risk of nosocomial and fungal infection. In hospitalized patients with the cirrhosis, the development of fungal infection is associated with increased risk of ACLF and increased mortality. In patients with the cirrhosis with history of SBP, we suggest the use of antibiotic for secondary SBP prophylaxis to prevent recurrent SBP. In patients with the cirrhosis in need for the primary SBP prophylaxis, we suggest daily prophylactic antibiotic, although no one specific regimen is superior to another to prevent SBP. In patients with the cirrhosis, we suggest avoiding PPI unless there is a clear indication, such as symptomatic GI gastroesophageal reflux or healing of erosive esophagitis or ulcer, because PPI use increases the risk of infection. So, some key concept statement. Non-selective beta blocker may decrease the bacterial translocation, but patients with ACLF have difficulty tolerating clinically relevant doses. Rifaximin may prevent the complication of cirrhosis other than the hepatic encephalopathy. Concentrating or avoiding IV medication that require large sodium load can improve volume status in patients with ACLF. Now, the non-infectious precipitating factor. In patients with the severe alcohol-associated hepatitis, that is MELD score of more than 32, or that is MADRE discriminant function of more than or equal to 32, and MELD score of more than or equal to 20 in the absence of contraindication, we recommended the use of prednisolone or prednisone 40 mg per day orally to improve 28-day mortality. In patients with severe alcohol-associated hepatitis, we suggest against the use of pentoxifylline to improve 28-day mortality. So we should use steroid, and it has a strong recommendation. So some key concept statement: this alcohol-associated hepatitis leads to ACLF as a result of combination of severe SIRS and sepsis. Now the next is drug-induced liver injury. Both prescribed and non-prescribed medication can cause drug-induced liver injury. And the most common prescribed medication that cause drug-induced liver injury are antimicrobial. And safe medication with the complementary and alternative medicine is common, spreading often through the social media. Actual prevalence of ACLF related drug-induced liver injury is unknown because the drug-induced liver injury is often under-reported. Most patients have the uneventful recovery. When drug-induced liver injury causes liver injury, it usually causes acute liver failure. Formal studies in patients with the pre-existing liver cirrhosis are lacking. Estimated incidence of Asian countries is approximately 10%, and that in the United States is approximately 7%. Drug-induced liver injury in setting of advanced liver disease carries the high risk of poor prognosis. Onset of ACLF occur on average 1 month after taking offending medication, but can be delayed for up to 3 months. Mortality in the drug-induced liver injury related ACLF is more than 50%, and with ACLF grade as the only significant predictor of the mortality. Patient education about limiting the use of pharmacological agent and avoiding the use of CAM, that is complementary and alternative medicine, is key to the prevention of drug-induced liver injury associated ACLF. Patient with underlying liver disease should be monitored when prescribed new medication with hepatotoxic potential. Now, the next is viral disease. Patient with underlying liver disease can develop ACLF if they contract any of the known viral hepatitis. Hepatitis B flare are the common cause of ACLF in Asian countries and may present like acute liver failure. Hepatitis B flare often occur in patient either spontaneously or abruptly stopping their antiviral medication. Other viral infection that causes ACLF are hepatitis A, E infection superimposed on the chronic liver disease and hepatitis, or hepatitis D superimposed on hepatitis B infection. Bacterial infections are the common trigger of ACLF in patients with viral hepatitis, which should be monitored for and treated promptly. Vaccinate patients with the chronic liver disease against the hepatitis A and hepatitis B if they are not already immune. Then, about surgical procedures, surgery of any type in patient with cirrhosis is associated with significant risk of organ failure and ACLF development when compared with patient without cirrhosis. In patient with cirrhosis contemplating surgery, both Mayo Clinic score and the vocal pain score are available online for calculating risk of mortality with surgery. Acute hepatic decompensation and presence of infection are significant risk factors for development of ACLF after the surgery. The development of ACLF after surgery is associated with significantly reduced survival compared with patients without ACLF. Patients with cirrhosis who require surgery should be carefully selected because perioperative management of such a patient also impacts survival. Non-surgical intervention can also precipitate ACLF, but the exact incidence is unknown. It seems that patients with more severe liver dysfunction, they are at high risk of development of ACLF with ERCP. For every non-surgical intervention proposed for cirrhotic patient, it is imperative to weigh the risk, benefit, and potential for ACLF development. Patient need to be closely monitored in the post-procedure period for development of ACLF. Then regarding general care, management of ACLF patient is accomplished by the multidisciplinary team approach, including expertise in critical care and transplant hepatology. The goal of treatment is the reversal of precipitating cause, treatment of sepsis, support the failing organ, and liver transplantation. So if there is a hepatic encephalopathy grade 3-4, we need to protect airway. If there is a hypoxemia of the PaO2 of less than 80, then we should go for chest X-ray, CT, evaluate hepatopulmonary syndrome, consider therapeutic thoracocentesis and FiO2. And then if the patient develops hypovolemia, then volume challenge using echocardiographic monitoring. If hemoglobin is less than 7, transfuse RBC. If MAP is less than 60 and if the patient is having septic shock, then assess the volume and evaluation for the GI bleeding. For sepsis evaluation, we need to investigate the patient, like we need to go for paracentesis and the blood culture. Ascitic tapping, urine chest X-ray and lactate. Then treat the underlying infection with appropriate antibiotic. Then we need to follow the general measures like resuscitate patient properly, DVT prophylaxis, trace prophylaxis. If the map is, if the patient is hypotensive with septic shock, then start with norepinephrine and hydrocodone. Regarding nutrition part, in patient with the cirrhosis who are hospitalized, we suggest against the routine use of parenteral nutrition, enteral nutrition, or oral supplement. Caution is advised when using enteral nutritional support in those with a high risk of aspiration. Then specific treatment regarding the use of albumin. In hospitalized patient with the cirrhosis, we recommended against the daily infusion of albumin to maintain the serum albumin level of more than 3 to improve mortality and prevention of renal dysfunction or infection. This statement has a strong recommendation. The key concept is albumin has a several potential benefit beyond oncotic effect. IV albumin is recommended to prevent AK and subsequent organ failure in patient diagnosed with SPP. IV albumin is not recommended to prevent organ failure in patient with cirrhosis who have infection other than the SPP. 5% albumin is often used for rapid volume resuscitation, whereas for more sustained volume expansion, we recommended 25% of albumin. Then intervention other than the transplant and specific organ support. Artificial liver support system with or without biological component theoretically can take over some of the function of liver, but whether they provide any clinical benefit is still unclear. Plasma exchange has been shown to improve survival in patients with acute liver failure. However, its effect in the ACLF is unknown. Then the next is use of granulocyte colony stimulating factor. In patient with the cirrhosis and ACLF, we suggest against the use of granulocyte colony stimulating factor to improve mortality. In patient with the ACLF, the administration of granulocyte colony stimulating factor has been shown to reduce short-term mortality in adult cohort in Asia, but not in Western cohort or in children, suggesting the impact of granulocyte colony stimulating factor may vary according to the precipitating ACLF factor and other unmeasured confound. Stem cell therapy represents a novel and promising therapeutic strategy to bridge the patient with ACLF to more definitive therapy. But evidences to support its use in the routine clinical practice is currently insufficient. Now, regarding liver transplantation in patients with cirrhosis and ACLF who continue to require mechanical ventilation because of adult respiratory distress syndrome and brain-related condition despite optimal therapy, we suggest against listing for liver transplantation to improve mortality. In patients with end-stage liver disease admitted to the hospital, we suggest early goal of care discussion and, if appropriate, referral to the palliative care to improve resource utilization. So these are the criteria for the liver transplantation. So according to the King's College criteria, if the ALF is due to paracetamol, then the criteria are pH should be less than 7.3 after resuscitation and more than 24 hours since ingestion. Lactate should be more than 3 or 3 following criteria should be met, like hepatic encephalopathy grade of more than grade 3, serum creatinine of more than 3, and INR should be more than 6.5. And if the ACLF is because of the non-paracetamol etiology, then the INR should be more than 6.5 and the 3 of the following criteria should be fulfilled. Etiology, intermittent etiology, hepatitis, drug-induced hepatitis. Age should be less than 10, more than 40. Interval between jaundice and encephalopathy more than 7. Bilirubin more than 3 and the INR more than 3.5. And then there is a cliche criteria for the liver transplantation. That is hepatic encephalopathy 3 to 4, factor 5 less than 20% of normal if age is less than 30, and factor 5 less than 30% if age is more than 30. Then we'll see what are the contraindication for liver transplantation. Contraindications are extrahepatic cancer other than the skin cancer, anatomical abnormality that preclude the transplantation, then the illicit drug use, AIDS, advanced cardiac disease. Then case by case assessment, sustained hemodynamic instability requiring high vasopressor administration, large hepatocellular carcinoma and those with the vascular invasion, metastasis to the liver from the treated hepatic, extrahepatic primary tumor, intrahepatic cholangiocarcinoma, marked frailty, fulminant hepatic failure with likely brain injury, then alcohol use disorder with the recent consumption of alcohol, current use of cigarettes, inadequate social support, history of frequent non-adherence to the medical management, and condition not considered to be contraindication like advanced age, obesity, sepsis confined to liver, and HIV infection controlled by heart. Thank you.